All right, well, thank you for coming back after lunch. I hope that now our challenge always, of course, after lunch is to make sure that the audience doesn't fall asleep while we give a presentation. But we've taken care of that with two very good speakers who are going to give us some information about lactate. So this session is lactate measures when, why, and how much. For this session, I'd like to introduce Dr. Tom Shaughnessy, who's the medical director of the EICU at Sutter Health. And for those of you that have been wondering why every person, every speaker that is accompanying the campaign is from Sutter, it's pure accident. We invited a number of people to join these sessions, but from different health systems, but due to scheduling reasons, they were either not able to join at a certain time or whatnot, and it's turned out to be that our speakers just happened to come from Sutter. But we're an equal opportunity campaign, and we expect all the different health systems to participate, and we're delighted in all the work you're doing. I also would reintroduce Dr. Dellinger, who I introduced in the previous session, who will speak in during this piece as well. And so without further ado, Dr. Shaughnessy.
Hi there. Hi there. My name is Tom Shaughnessy. I am, as Sean mentioned, the EICU medical director for the Bay Area at Sutter Health. I'd like to thank the Moore Foundation for having me here today. And what I'd like to kind of talk about in this brief little interlude I have with you is some of the issues that kind of cropped up since the last meeting we had in March concerning questions around lactate, and more or less try to structure this and set it up a little bit for some further elaboration by Dr. Dellinger, but also to try to crystallize some of these issues so that perhaps we can have a more spirited debate about them or discussion about them in the question and answer period. Well, the interesting thing here is I took a poll of the laboratory directors at the various facilities in the Bay Area region, and I found out from those directors that the volume of lactate levels that have been ordered and run throughout the last 5 years has increased by about, say, 1,000%. Now, that's good, but it also creates a little bit of a problem because lactate in general has become ingrained in our thinking regarding sepsis to the point where it's become easy to think of lactate as being pathognomonic, a pathognomonic indicator for sepsis, as an identifier of the disease. And that's really not what lactates are about. They're really a marker of malperfusion, not necessarily a pseudonym of sepsis. Because I often hear now from the various doctors that I deal with throughout the system, and I tend to take a system perspective on things, is it can't be sepsis because the lactate isn't elevated. And when you go back in the literature, and I'm not really going to show a whole lot of data and slides and things like that, but just kind of give you a feel for what the weight of the literature shows when it concerns lactate, is that a significant amount of cases, maybe up to 15 to 30%, in fact, have other manifestations of end organ dysfunction that is independent of lactate, that may or may not be associated with elevated lactates. The hypotension, bilateral infiltrates, all these elements that you see here are end organ dysfunctions that meet the criteria for severe sepsis and oftentimes are not associated with an increase in lactate. So it lends to an interesting question. How do you get the word out that, that not everybody has to have an elevated lactate in order to have severe sepsis without diminishing the importance of the study and it has on our ability to diagnose and manage the disorder? So I'll just leave that with you to think about that one a little bit because I'm not sure I have the right answer myself. But it's also important to realize that the converse is true as well. Not every elevated lactate means that the patient is septic. Lactates come in two varieties, a type A, which is caused by hypoperfusion and conversion to anaerobic metabolism. And then there's a type B and various subcategories of type B, which also include hyperlactatemia as a manifestation, but can also be accounted for by toxins, alcohol, malignancies in extreme cases, and inborn metabolic errors. And it's very interesting because another doc keeps telling me that his patients aren't septic because they all have type B lactic acidosis. And he must be the luckiest or unluckiest doc in the world because almost all his patients seems to have type B acidoses. So the interesting thing about all this is that when you look at things in the aggregate, while lactate in general is not perfect in terms of its specificity or sensitivity, and it may not be the end-all be-all for the diagnosis of sepsis, when you look at things in terms of the available biomarkers that are available out there, lactate has come to have the most support to identify patients who have adverse outcomes. Now remember, I didn't say sepsis, I just said support to identify adverse outcomes. Typically, when you have an elevated lactate, you have something bad happening to the patient in general. So towards that end, it may or may not be sepsis, but definitely it's worthy of care, of further care. Now, given that the aforementioned issues surrounding the use of lactate in terms of the diagnosis of sepsis, I'm often asked, well, when do you use it and why do you use it, and under what circumstances does it serve us the best? Well, as I mentioned, from the EICU perspective, I tend to look at things from the screening and outreach component in the ICU. I see, well, not to diminish its role as a diagnostic tool, which it certainly is, sometimes one of its best uses is as a screening tool. Now, that brings up another issue, which is screening versus diagnosis. And I'd like to kind of crystallize this in, my bad. I'd like to crystallize this in people's minds is that screening is screening and diagnosis is diagnosis. Screening is, happens in the moment, right up front. And diagnosis happens usually well into the course of a patient's care. Screening is meeting a predetermined threshold of criteria, and diagnosis is considered clinical judgment. So, in short, screening is more or less about getting all the apples into the basket, and diagnosis is about sorting those apples out, good apples and bad apples. But because sepsis is common, and common things are common, like I didn't mention, but the type A lactic acidosis versus the type B, the overwhelming majority of lactic acidoses out there are type A. And because the context of which, when we talk about when these tests are being ordered for septic conditions, and that is a common element, common malady that's going around, it makes us have to assume that when we screen people, we have to assume that it's sepsis until we can prove otherwise. And so it follows that appropriate treatment needs to be given and should prevail until that time. The interesting thing I tell that doc about the type B lactic acidosis is that, well, that may or may not be true, but you can't necessarily rule out that the more common cause is the type A, and you really won't know whether it's type A or type B until you've done some resuscitation. So either way, you're kind of stuck with the care being that you have to assume that it's sepsis until proven otherwise, and then follow a treatment protocol until you can basically afford to call it off. Now, one of the other, I think, best uses of lactate measures is in terms of monitoring a patient's clinical trajectory. And towards that end, as everybody knows, lactate tends to be considered a trigger for early goal-directed therapy. Now, I'm not going to go into the exact triggers because that's well versed in the Surviving Sepsis Guidelines, and we've covered that in previous sessions. One of the interesting things about lactates right now is that it can be used as in serial assessments to help guide early goal-directed therapy management and as part of the ongoing resuscitation management, but it can also be used to monitor a patient in terms of their trajectory, in terms of getting worse or getting better. So it brings about the question of when. When does one order a lactate? Well, if you look at the bulk of the literature out there that concerns lactates, most would fall at the admission as being the most important time with which to do a screening lactate, because it's that time when lactates tend to have the greatest predictive value in terms of prognosis. Towards that end, predictive value tends to be the most significant when lactates get greater than 2 to 2.5 millimoles per liter on admission. Now, there can be some debate as to what constitutes admission. Is it triage? Is it admission to the ICU? Is it ED evaluation? It's unclear because the literature is kind of all over the place in terms of how the studies are structured. But be that as it may, I think that everybody would agree that admission is a relatively defined window or finite window where a trigger that's greater than 2 to 2.5 should be somewhat of a cause for alarm. So it can be used in various ways. It can be used to establish cases of severe sepsis. That is to say, lock in the diagnosis in terms of meeting the criteria for it. But it can also take a confusing case and throw it into the realm of being potential severe sepsis. That is to say, meeting the threshold of criteria of a possibility of severe sepsis based on the clinical constellation of signs and symptoms. We don't necessarily knowing that cryptic sepsis can be such a significant component of the population. Oftentimes, we don't stand on the ceremony of two SIRS criteria. Just having one plus an evidence of an end organ dysfunction is enough to throw somebody into a potential diagnosis, at least makes them worthy of continued monitoring and follow-up. Probably, I think, one of the most important areas where lactate or serial lactate measurements can be most effective is as a tool to determine level of care decisions. And we've probably all done that tacitly at our own institutions, and that is in terms of deciding where a patient goes. Should they go do they go to ICU, or do they go to a step down, or do they go to the floor? What constitutes the appropriate level of care? Oftentimes the lactate measurement may not be the end-all discriminator of where the patient goes, but it certainly becomes a factor. I'm sure everybody's kind of worked that into their own policies and procedures and protocols in their EDs. One of the interesting questions that kind of cropped up from the last session was in terms of asking the question of, well, what's the optimal time for serial assessments of lactates? And I'm sorry to say the literature is not terribly robust in this area, but it's very easy to tell you that I don't think there's any definite consensus in terms of what that time interval should be. What I can tell you is that when you're using lactates to help guide management, the interval tends to be in the terms of 1 to 2 hours. But when lactate is being used for prognostic purposes, it can be up to 24 hours. Now, most studies, though, tend to look at interval levels between 2 and 6 hours. So if I had to make a guess in terms of what the optimal time interval based on just, the smattering of literature alone, probably say something in that interval. Now, this is where I get to make a personal assessment about this, because we tend to see a lot of these borderline patients all the time who have lactates in the range of about 2 to 4, which meets the criteria for severe sepsis, but not necessarily a trigger for early goal-directed therapy. So what to do about those? And that was another question that kind of came up from the previous sessions as well. Well, once again, going back to the optimal time interval for assessment, one would suggest maybe 2 to 6 hour intervals. But based on what I see in common practice, I would, because I tend to sit on the critical care committee for my hospital, so I kind of review all the QA events that happen from rapid response teams and things like that. I would have to proffer that next day writing for check lactate in the morning with morning labs probably isn't the optimal way of dealing with it, because I tend to see a fair amount of patients who hit the ICU in the middle of the night who had that written on their orders. So finally, one of the other areas that came as a question was, well, what's the optimal site? Where does one get these lactate levels? It's kind of an ancillary type question, but there may be a little more data to help guide us. Now, the gold standard is arterial blood measurements, but that's somewhat problematic because it's a kind of a high-stress thing to do. It tends to be a little more difficult to get and can be somewhat more time-consuming. Now, fortunately, point-of-care testing has been looked at quite a bit in contrast to arterial blood as well, and tends to have a pretty high accuracy versus laboratory assays. And in fact, when you look at things like capillary measurements and venous measurements versus arterial measurements, most studies tend to find a pretty satisfactory agreement. In general, though, the venous and capillary results tend to overestimate the arterial results by a little bit, maybe about 0.2 millimoles or so. Excuse me. But the big advantage here is that venous and capillary sources offer a substantial more ease of measurement. They're faster to get. And because you can get many of them much more quickly in a row, they allow for more consistency with testing, particularly that trajectory thing that I had mentioned a little bit earlier. And the fact that the venous and capillary sources tend to somewhat overestimate the arterial sources means that if you're using the same trigger thresholds that we had mentioned before, that at least when you're using this for screening purposes, actually using the venous and capillary sources may be somewhat of a better screening tool because you're more likely to capture a larger population. And remember, screening is screening and diagnosis is diagnosis. So the purpose of screening is to capture not only all the established easy cases of severe sepsis, but also those that possibly were severe sepsis. If you're not doing that, then you don't really have a screening program, you actually have a diagnosing program. And if you're going to have a screening program that works up front, then that triggers and alerts and alarms, you're going to have to accept the fact that, that you're always going to have an N in your screening population that is much greater than the number of patients who actually ultimately get diagnosed. So with that, I think we can move on to Dr. Dellinger and then move on to hopefully a very robust discussion about how to use lactates.
Tom, that was very good and just a perfect intro for my comments. I'm going to now talk about lactate not from a diagnostic or prognostic standpoint or a triage standpoint, but instead as a potential target for what the Surviving Sepsis Campaign now calls quantitative protocolized resuscitation of sepsis-induced tissue hypoperfusion. This is just a brief reminder of all the things that are going on in the septic shock patient with the leak from the capillaries and increase in venous capacitance, producing a decrease in intravascular volume and blood returning to the right heart, decreased contractility in most of the patients, decreased arteriolar resistance, which is probably advantageous in the patient that is not hypotensive, and sinus tachycardia. It has been argued that for the sepsis-induced tissue hypoperfusion patient, perhaps the A, B, C, D, E of the emergency management should be endpoints of resuscitation. This is Cooper's protocol. I think that for sepsis-induced tissue hypoperfusion, I think it's good for each hospital to have their own protocol that everyone signs into. Step one is fluid resuscitation, trying to replace the intravascular volume to an amount that will allow the ventricle to function optimally. CVP is what's currently recommended, primarily because it is doable within that first 6 hours versus other options for assessing preload, which are very difficult to get in. The Surviving Sepsis Campaign recommends mean arterial pressure of 65, CVP of 8, and a urine output of 0.5 mLs per kg per hour. Our new fluid recommendation, initial fluid challenge in sepsis-induced tissue hypoperfusion, hypotension, or elevated lactate with suspicion of hypovolemia, to be a minimum of 30 mLs per kg of crystalloids. A portion of this may be albumin equivalent. More rapid administration and greater amounts of fluid may be needed in some patients. We were discussing at the back of the room over lunch, where does the 30 mLs per kg come from? And there isn't a high level of evidence for 30 mLs per kg. I can tell you that when the group that sat in 2008 and back in 2004, when we created the bundles and then looked at whether we would change them, there wasn't anyone of the international experts that thought that 20 mLs per kg was too much. There was clearly a very vocal minority, but significant minority, that felt that 20 mLs per kg was not enough. We did decide to go to 30 mLs per kg for the recommendation and for the bundle. This is a meta-analysis that supports quantitative resuscitation strategy. If you look at all the trials that have targeted early, aggressive, goal-targeted resuscitation of sepsis-induced tissue hypoperfusion, and you look at those that went after early sepsis. I'm not getting a laser here. So here you can see that the key is getting patients with sepsis-induced tissue hypoperfusion early versus late. Here you can see that there is a significant meta-analysis effect. Current resuscitation bundle, that's this slide. Currently recommending a CVP of equal to or greater than 8, higher and decreased ventricular compliance or increased intrathoracic pressure. The new guidelines also recommend that dynamic variables, not static variables, but variables that instead of having one specific target like a CVP of 8, that you would use things like systolic pressure variation in mechanically ventilated patients, where you do an inspiratory hole and you look at the variation on the arterial line and the systolic pressure. And the more variability you have with the systolic pressure with an inspiratory hole with volume ventilation, the more likely your patient will respond to additional fluids. We mention measurements of flow such as pulse contour, stroke volume. It inherently makes sense that the ultimate target of fluid resuscitation would be to know whether the fluid resuscitation increased stroke volume, because that would be why you're giving the fluid, in order to increase stroke volume. This allows you to get closer to stroke volume. The problem with this technology is you couldn't get it in for this early critical part of resuscitation of sepsis-induced tissue hypoperfusion. Now let's turn to the current recommendation, which has been in place since the initial guidelines and bundles, which is to target an SCVO2 of 70%. We don't recommend that you have to use a continuous device. Many institutions, even those with very strong, vibrant programs in severe sepsis performance improvement, do intermittent measurements with a venous blood gas. The advantage of the continuous is shown here, in that you can detect a drop in the SCVO2 as an early warning monitoring sign. This is where there is a lot of buzz currently with use of lactate clearance. This is a study that was published in JAMA in 2010, in which 150 patients were randomized to lactate clearance to achieve at least a 10% decrease in lactate over the same early goal-directed 6-hour period. The way this study was done is that patients were consented for this study that had lactates, that had sepsis-induced tissue hypoperfusion with a lactate of 4 or greater, or hypotension after 20 mLs per kg fluid. They were randomized to either traditional early goal-directed therapy or lactates every 2 hours to reach a target of a 10% decrease in the lactate, using beyond fluids blood if the hematocrit was less than 30, or dobutamine if the lactate clearance was not achieved. You can see that there was no difference in the outcome between using SCVO2 versus lactate clearance. This has been used as an argument by some people that lactate clearance should be an alternative to targeting SCVO2 in patients with sepsis-induced tissue hypoperfusion. I think one of the things you need to understand about this study is that although there were 300 people that started at the top of this study, when you actually got down to that first break point where the actual head-to-head comparison went, that was after that initial fluid resuscitation, there were very few patients in either group. It actually is a very small study. One of the things that I learned from looking down at the very intricate details of this study is that most patients, just with the initial fluid resuscitation, achieved either a normal SCVO2 in most cases or a 10% decrease in lactate in most cases. That there really weren't a lot of patients left to think about dobutamine or blood. In fact, there were only 29 out of 300 patients that went into that second part of the study where they got either dobutamine or blood. This is another study that looked at lactate clearance. Again, every 2 hours, that showed that the lactate group did better than the control group, but the control group did not get SCVO2 targeted therapy. In fact, the lactate group, many of those patients got SCVO2 targeted therapy in addition to lactate. So this is more of an adding lactate on to SCVO2 as opposed to a head-to-head comparison. Our new Surviving Sepsis Campaign is that with tissue hypoperfusion associated elevated lactate levels, suggests targeting lactate normalization as rapidly as possible. There was a lot of discussion about using lactate as a target. To be honest with you, the thing in the end that led to lactate being a suggestion and lactate being a normalization is that the argument was made that if you started out with a lactate of 10 and you went down by 2 to 8 with resuscitation, you would have achieved a 20% reduction in lactate, which would have been significantly beyond the target that was used in the Jones study. That example, I think, somehow solidified in the committee the thought that, well, this doesn't make sense. You know, I shouldn't feel happy going from 10 to 8. I think we felt happy with getting rid of lactate. We felt good about bringing lactate down, but to use a 10% reduction as a target just was not something that was palatable. There is a sub-study coming out from the Jones study that shows that most of the treatment benefit in that study was in patients that had the lactate normalized. I'll just throw out a couple of things that we're seeing appear in the literature that could be done quickly. That's looking at the arterial venous CO2 gap. If you, with sepsis-induced tissue hypoperfusion, the tissues are hypoperfused. There's evidence of anaerobic glycolysis, lactate production, CO2 production. So you get a CO2 buildup in the tissues in sepsis-induced tissue hypoperfusion. But you don't see that in the arterial blood because the CO2 is taken out by the lungs. So the arterial CO2 remains normal based on your CO2 elimination capability. But that CO2 that's coming back in the venous blood from the tissues, the amount of CO2 that's in that venous blood correlates with your degree of tissue hypoperfusion. And therefore, the difference between the arterial and the venous PCO2 becomes a marker of tissue hypoperfusion and is a target that you could get from having a central line and an arterial line in which you just have to pull 2 simultaneous blood gas specimens in order to get that. And I'll stop there, and I guess Tom, we can...
Very good. Thank you both. And if we could bring the screen up in the back. Well, same rules apply to this session as previously. If you have questions or comments, please approach to my right at the microphone, and you'll be able to have your questions taken.
And I know Ron has, had a lot of experience working with lactate, and I'm sure I see he's very active on the listserv in that area as well, and hopefully he'll weigh in at some point in time.
Yeah, I guess I would start off with a question while you're all forming your thoughts and preparing to tell us about your experiences with lactate. It sounds like from listening to both of you speak that there's it's fair to draw a distinction between lactate as a screen and lactate as an endpoint. So Tom was mainly discussing the use of lactate for screening purposes, it seems, and then the discussion that you were just having at the very end of your talk, Phil, was mainly about resuscitating someone to a certain lactate level. And the distinction between the two is important because they're very different purposes. So what do you do then if you're using lactate as a screen, Tom? There are thresholds. You said 2.0 to 2.5 gets you to admission, pretty much, in most facilities.
In my book, it buys you as either making a diagnosis or being a potential diagnosis.
But you were careful not to say admission where. It gets you
Admission,
in the house.
Oh, gets you into the house.
Right.
Yes. The question is, where does it get you? And I think everybody is actually struggling with that kind of an issue right now because part of it is resource constraints that may dictate that. Mm-hmm. I found it very interesting with Dr. Levy's comments about Europe. And I think what guides their decision tree is the ratio of ICU beds to hospital beds. We have that here too. Smaller hospitals may have a threshold to, who have less ICU beds, has less capabilities of just putting people in the ICU.
And what occurred to me while listening to both presentations was that the threshold you had mentioned for admission to the hospital, whether it's the ICU or the wards or what have you, could be the resuscitation endpoint for someone who started off with a higher lactate, a lactate of 4, as if they've been allegedly fully resuscitated if you just use lactate as an endpoint.
Certainly, when we follow the trajectory of a resuscitation, we're looking for a resolution of that lactate. And indeed, I think that there's pretty strong evidence that when you use that threshold level or trigger level of 2, 2.5, that's where you start getting the significant mortality changes. So that's where you can kind of breathe a little easier once they're resuscitated to that degree. But I think the question is how often to look at that is one thing, because I think that a lot of people here may be getting a lot of grief about how many lactates they're being ordered. But it is a relatively convenient test. And as a biomarker of resolution of malperfusion, regardless of whether it's due to sepsis or not, I actually kind of think it may be better thought of as a resuscitation endpoint as opposed to a sepsis endpoint.
Phil, would you say that that there's the extreme worldview that lactate by itself could be a substitute endpoint for SCVO2, but the Janssen paper, is my understanding, also concludes that it's not a substitute measure, unlike the Jones paper. The Janssen paper suggests that it's best used in correlation with SCVO2 and CVP as an endpoint.
That would be, or totally clearing lactate. The committee just did not feel comfortable with telling people that a 10% reduction in lactate was an endpoint. For total normalization of lactate, I think most intensivists would say that is my goal in a patient that I admit to the ICU with severe sepsis and a high lactate. I'm going to feel most comfortable when I've normalized it. I think it's impractical sometimes to say that you can do that in 6 hours. If I have a patient that has a very high lactate, I would anticipate that the ability to clear that in 6 hours is going to be often difficult to impossible, and would not be used as a marker for me of whether I did a good job on resuscitation or not.
Can I ask, do you think that the Jones and Janssen paper provides some rationalization for not putting in the central line? and just using lactate, serial lactate measurements alone?
Not if you use the 10% target, because I think that what that study showed is if you give 4.5 liters of fluid with the early resuscitation, most patients are going to normalize their SCVO2 and 10% reduce their lactate. And those that are left are going to be very small numbers. And that if you do an equivalent study and you've already, the two approaches are equivalent already with the great majority of patients just with fluid because you've already hit your target. It's very easy to show equivalence with just a small fraction of the patients that are left.
Looked at a different way, if you think about the logical conclusion to what you just said, Phil, shouldn't the endpoint be, did you get 4.5 liters of saline? Rather than following any lactate level at all. If the intervention that made the biggest difference in this 300 patient data set was 4.5 liters of saline.
And that's the hypothesis of the process trial that has been going on for a very long time, which is if you just give significant amounts of fluid, do you really need to measure SCVO2 or maybe lactate or anything? You know, the key is just very generous fluid resuscitation. And, you know, that might be supported by the fact that, you know, most of the patients in this study hit the 70% SCVO2 just with the initial fluid resuscitation.
Yeah. It's more persuasive to me on that point than it is on the idea that clearing lactate is an important thing to do.
I agree.
Just the question related to fluid resuscitation, and you've sort of mentioned it, and you may have answered my question. So we're having a little bit of difficulty in terms of, I know this is getting into less maybe I'm missing the forest through the trees here, but we're having a little difficulty in terms of measuring compliance with fluid resuscitation when patients do achieve sort of that, whether it's lactate clearance or SCVO2, and then subsequently drop again or worsen again. And how do we judge those patients with regard to compliance with fluid resuscitation?
This is a really interesting area, and the person I know who's looked at that question the most is actually Ron, and maybe you could comment on it, Ron, if you could get near a mic. But many times when we've looked at lactates internally at CPMC, where both Ron and I practice, we've had a number of patients. I can't cite the statistical validity of this in any possible way, but what often emerges is no particular pattern, so that patients are being resuscitated for a lactate of 3.5 with a certain amount of saline, and a couple hours pass and you've made it 2.7, and you've continued a marginal saline strategy, and the next thing you know, lactate's 4.3. And it's unclear whether you're looking at mechanisms of lactate clearance or actual elimination of lactate or dilution of lactate that accounts for the swings in lactate. So to say that you consistently see a decline with the administration of additional fluid, I think is something that we, in our experience at least, have not been comfortable saying.
Yeah, and it seems like that 6-hour mark is, while an important mark, it's a little bit arbitrary and within the, scheme of things in terms of patient after 24 hours or after even a longer period of time.
I think that's done for simplicity with the quality, with the performance improvement. Unfortunately, you have to sort of pick one time point, even though you would argue that there are a lot of time points that are important. With a bundle, you pick one time point and one goal, and you hope that that reflects good process before it and after it, that someone wouldn't say, okay, my lactate went back up, but I've already got it down once, so I don't need to worry about it anymore.
Well, I think that assumes that you have adequate source control or pathology. Maybe a better word is pathology control. because maybe they don't, maybe they have something else going on. A lot of what I utilize as a gold standard test to any kind of theory that, or management strategy that's out there is, gee, how will this impact on the patient who has a history of, who comes in with a history of CHF and pneumonia? And you know, you can't just run 4.5 liters in. Most ER docs won't do that. And or the dialysis patient, or however, whatever scenario you want to put out. But I guess what I'm pointing out is, how do you manage the complicated sepsis patient? You know, patients who have two different pathologies at the same time, and where there are more rationale for closer monitoring than less monitoring. So, and how the fluctuation in lactates look at any given time could be reflective of not a septic pathology, but some other comorbid condition going on. It's an alarm. I look at the lactate as an alarm of badness. Plain and simple, that's it.
Thank you.
Ron, if you could share some of your thoughts.
At the risk of putting everybody to sleep.
We'll take the risk.
I think you've touched on all the key points here, actually. When you see a serum lactate, what you're doing is producing it in excess of the body's ability to clear it. And the clearance mechanisms will vary from person to person. In the simplest model of lactic acidosis, a seizure in somebody with normal cardiorespiratory, renal, liver function, the half-life of a serum lactate is 30 to 60 minutes. But in the kinds of patients we're talking about, the half-life is many, many hours. And there are publications by Jean-Louis Vincent and Max Harry Weil that discourage the use of lactate as a resuscitation goal because of the extraordinarily long half-life in sick people. The lactate has to be related to production, and that will depend, as Tom said, on source control. It'll depend on whether your resuscitation falls off its tracks. It'll depend on catechals. And there are a huge number of metabolic influences that I think it's fair to say are very poorly understood. One tissue bed can be producing lactate, and the bed next door can be metabolizing it. Lactate shuttles, which Brooks at UC Berkeley has published about. So once lactate is produced, it has to get out of tissue into the serum, and there are a number of studies that show that that doesn't happen in shock. In normal health, the lactate in tissue and in serum are exactly the same. As you develop an increasing degree of shock, there's an increasing gradient between tissue and serum, and paradoxically, as the resuscitation begins and proceeds, as perfusion increases, you may see an increase in lactate. And you don't know, of course, in the individual case, whether that's due to poor source control, more production, tissue washout, or deteriorating clearance mechanisms. So it seems to be an extraordinarily complex number to measure, and a very crude measure of microcirculatory perfusion. When we look at our lactates, we've been looking at lactates for every 4 to 6 hours for a number of years, and when we look systematically, we find that they fluctuate in 1/3 of our cases. They go up and down. And they may go up and down once, or they may go up and down 2 or 3 times. There's a publication by a man named Hernandez from Chile. People that came in with elevated lactates and went to early goal-directed therapy, the first lactate was not the highest in 41% of patients. And the peak lactate occurred at 20 plus or minus 12 hours. So an enormous half-life here, if you want to think about half-life. It's not even fair to use the term half-life. And people that came in with lactates that were normal, about 10% of them had elevations later. So it's an extremely complicated issue. Now, if you want to target fluid resuscitation, if you look at the early goal-directed therapy, the early goal-directed group, it's true that the average patient got 5 liters of fluid, but the range was enormous. The standard deviations are enormous. and they vary between 1 and 11 liters in that first 6 hours, basically. And it has a lot to do with comorbidities, heart failure, so forth, so on. One thing that's worth remembering, congestive heart failure won't generate a lactate. What will generate a lactate is cardiogenic shock. That usually happens in cardiogenic shock with SVO2s that are 30%, 40%, or less. And with sepsis, you usually see the lactate with much higher SVO2s.
So you see that, I mean, the depth of the literature and the look that you've done into this matter is clear, but you advocate in your practice continually following lactates nonetheless, despite the variability and the numerous factors that you think go into
Yes.
clearance as well as production and measurement.
Yes, I believe the measures of microcirculatory perfusion are flawed, and that includes SVO2. With an SVO2, you don't know whether the balance between tissues is changing. You don't know whether there's cytopathic failure. There is a graph published by a fellow named Pope who found that the lowest mortality occurred at roughly 70% SVO2. If you were lower than that, the mortality rate went up. And if you were higher than that, the mortality went up. So it was a U-shaped curve. And presumably the high SVO2 people, many of them had that cytopathic mitochondrial failure.
Well,
So,
and I was just going to put it back to the panel for a moment. Yeah. Part of the evidence-based process for formulating the guidelines, Phil, included an evaluation of much of the literature that Ron has cited. In addition, a very close look at the quantitative resuscitation literature to see what exactly the evidence was that would justify the continued use of CVP and SCVO2 as quantitative endpoints. But I'll put a proposition out there and I'd ask you to respond to it. And the proposition would be, despite the literature that's developed around these topics and possible endpoints for severe sepsis and septic shock for resuscitation, the evidence is still not complete, and the confirmatory studies for any one study seem to be lacking.
I agree.
I mean, lactate is probably, I said it's a good biomarker. It's probably the best we have out there, but it's far from perfect. So it definitely has its limitations in terms of making a diagnosis and as an endpoint in management. But that just speaks to the necessity of integrating that as a component of making a judgment in terms of the clinical trajectory and not letting any one marker dictate care. Gee, if it was that simple, you wouldn't need to use any thinking at all.
And I think that's a point that I would have an interest in conveying to this audience to bring back home, is that we didn't settle on lactate clearance as a strategy in the guidelines. We ranked the evidence for what it appeared to be, which I think came out as a 2B or 2C in terms of the evidence. I can't even recall as a recommendation. And we'll see what that was. I've forgotten.
SCVO2 is a 1.
But I meant lactate clearance, though.
2.
2. It's a 2-something in terms of the quality of the evidence. So the point I'm trying to draw with that is that we've ranked the evidence, we've looked at it, we've evaluated it, but I don't think that the opinion of the panel was that we've got the last word on what the right resuscitation endpoints clearly are. We know that the early goal-directed therapy trial still stands to be the best established practice, and based upon the evidence that's come out since that time, although there will be many trials coming out in the future. There's Arise, Promise, and the third one, I can't remember the name of the third one, which we expect published within the next year, will have better answers to these endpoints. But to take home this, I think I could fairly say what you ought to do is look at all of these parameters and make an assessment of what your judgment is as to whether this person is on the trajectory to improvement in full resuscitation or not. And that's about as comfortable as I get with making decisions around this.
I think an elevated lactate with somebody who you're adding pressors to is a lot different than somebody who's got an elevating lactate but is decreased their pressor requirement. It kind of speaks to two different things going on.
Yeah.
If I had a low SCVO2, I would like for you to make it normal. And if I had an elevated lactate, I'd like for you to make that normal. But at the same time, I realize that even a high SCVO2, may be the worst prognostic sign. So there are caveats, but nevertheless, I still want to go from low to normal if it's low.
Same thing with the CVP.
Right.
Right? So that's the common misconception. It's not one size fits all, but if it's low, I agree with Phil. I want you to fix that. And if you see it like that, then I think it reduces the academic debate. Because we would all agree in the face of either hypotension or an elevated lactate, a low SCVO2 and a low CVP are really helpful. And if you keep it that simple, it's easy to understand what the recommendations are. Ron, would you disagree with that?
No, I agree with you. And we would like to see a normal SVO2, and we would like to see a normal lactate. And a normal lactate, to me at least, means 2 or 3 normal lactates in a row, so that you're not having to puzzle out the fluctuation problem, which seems to be a real phenomenon.
And I think the corollary would be true that an elevated lactate is cause for concern, regardless of,
Right.
of what the pathology is. Cause for concern.
Yeah.
I'm not sure if there's too many things out there that cause an elevated lactate that don't worry about it.
Right. And I know Manny Rivers' practice is to try to normalize both those values, SVO2 and lactate, as well as the other parameters, CVP and MAP.
So another question or comment?
Hi, Rich DeFelice. I'm both from the Sutter and the Mercy system. I'm an intensivist. I thought a number of years ago I really knew how to use CVPs, and as I use them more, I'm less and less convinced that I do. And we obviously, it's a dynamic thing. There's ways of managing it, but I've even noticed that patients with low CVPs occasionally, clinically, they look overloaded. Have people looked at all these other things that we use to demonstrate appropriate volume and how CVP really correlates with that?
Well, I mean, anytime you want to look at correlation with a variable, you take two things. You take CVP and you take left ventricular volume. And there the correlation is poor, but you're looking all along the line. You're looking, a low CVP, what does it tell you about left ventricular volume? An intermediate, what does it tell you about left ventricular volume? A high, what does it tell you about left ventricular volume? Because that's the only way that you do a statistical analysis for correlation between two variables. Having said that, a low CVP has a good receiver operating curve for correlating with a low left ventricular volume.
So you're reasonably comfortable, I mean, we all do this, try to push the CVP up to at least 8 and often significantly higher than that.
I think a low CVP, you should feel comfortable taking that up to the 8 to 12 range, yes.
And I think the harder question, and the one that none of us answers well, is I put the line in, I leveled the patient and the catheter, and the CVP is 8. And what does that mean?
It means you usually give fluid if they're still sick, but then you've given, let's say, multiple liters of fluid, and they're starting to look wetter than they did before, and this could be ARDS, it could be other sorts of things, but you've given them now 10 liters, and the CVP is still on the low side, and I've had those cases where I've been quite uncomfortable with the 13th and 14th liter in the face of a low CVP still. And we don't have other things, at least at the bedside. We try to get an echocardiogram, and sometimes it's difficult to get it at that time, where if it's in the middle of the night, et cetera. But making those fluid decisions are problematic.
So Phil showed some of the more advanced techniques that are available to assess left ventricular filling, essentially, using non-invasive methods. And there are a number of them that are out there, and none of them are particularly well tested in this scenario for this set of patients versus a gold standard at this point that we felt comfortable recommending that any of their use as part of this program. And then there's we're about practical things here, right? We're talking about improving the quality of care for patients immediately, for patients who are in a time-sensitive diagnosis. As a practical matter, whether you can get those types of non-invasive setups up and running in a patient, whether they were effective or not, is another question. So we've resorted to CVP to a large extent because it's easy and it's available. And I think if you keep Mitchell's perspective that when it's low, then we can say a lot about fixing that, and then questions emerge about when it's medium or high.
Certainly when the patient doesn't behave as expected to the interventions, then it speaks to needing another diagnostic tool to help delineate what's going on. It sounds like that kind of situation is more an exception than the rule.
Yeah, it occurs occasionally, not the rule.
Yeah,
I mean, the guidelines are based on what happens in most patients, but
I would say that typically if people don't respond after the second intervention as expected, then typically you're needing a different diagnostic tool or a different therapy or something like that.
I think we had a comment from Mitchell, and then I'll take one more question before we finish for the next session.
I think that's the key point. And so I hear your example, but I see that but rarely. And unfortunately, we use those exceptions to prove the rule, especially, and I'm not saying you don't like CVPs, but for a lot of the folks who hate the fact that we use CVP, there's a convenient overlooking of the fact that what we're saying is a low CVP. What we've just been saying is extremely helpful. And in our hands, and we've seen a lot of this in our ED, 95+% of the time, the CVP is high, and so you can't make any sense out of it. It's a rare exception that after 10 liters of fluid, someone's CVP is still 6 and they're hypotensive. And for those folks, all bets are off because